We think we've identified, $6 billion of savings opportunity in the last year for patients. So we're proud of that. We also did a study. This one's wild. We did a study trying to find where there were $0 options for doctors that they weren't aware of. So we found that almost 50% of the time there was a $0 option drug available when the provider selected a drug that was $50 or more. So almost half the time there's a $0 option out there. And our job is just to get that in front of the provider, right?
What? Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. Excited to be sitting here with wonderful CEO Kyle Kiser, CEO of Arrive Health, which is a fantastic name, just by the way. And so, Kyle, thanks so much for spending time with us today.
Yeah, glad to be here.
So let's jump right in. Where'd you grow up, and how'd you get into healthcare?
Oh, nice. I grew up in Northwest North Carolina, just outside of Winston-Salem. I live in the Pacific Northwest now, so they're not close to one another. My family's business was actually employee benefits. So my dad was employee benefits consultant, and I remember from an early age delivering Christmas gifts to the clients and stuff. Didn't stand a chance. When I got in trouble in school, if I got sent home from school, which I think only happened once, I had to come home and stuff enrollment packets. So I didn't have it. I was always going to be in healthcare. Like that was the path.
That's great. That's awesome. And you were taught work ethic from a young age.
Yeah, absolutely.
So it seems nice. And so talk to us about Arrive Health. How did you say you've been there for a while? It's 9 years or so. What is Arrive Health? And it's obviously very different today than when you started. There's been a rebrand. So tell us.
Yeah, totally. Yeah, well, origins are the same. So this guy named Kevin O'Brien, who's still a doctor in Denver, one of the co-founders. This was all really inspired from Kevin and his mom's interaction. So Kevin's mom came to him, had an out-of-control monthly prescription spend, asked for help. And, like any good son with the skill set, Kevin looked at her meds, found ways to save. So he, took the brands and broke them into their generic parts where possible. He found therapeutic alternatives for some. I think he even maybe recommended some pill splitting in some cases, and saved her a bunch of money on her meds. And what that inspired him to do was ultimately start doing this at his clinic. So he started to manage this spreadsheet at his clinic that was ways to save on medication. He wasn't doing this because, he was in some value-based agreement. He wasn't doing this because doing that made him any more money as a doctor. He just saw patients suffering, and frankly, the only medications that work right are the ones that people can afford. And so, in his view, doing good clinical medicine required now taking into account cost, and so that's the seed from which we've grown this whole thing, and we still feel very connected and oriented around that. In fact, we have a mantra in the company called Lucy Up. And it's like our way to say, it's time to step up for the mission, or when we're way too in the details, well, then you can lift your eyes and say, like, this is what this is about. And it's because Kevin's mom's named Lucy, and everybody's got some experience like that, right? Like somebody in your family, somebody maybe even yourself, have had some experience with the healthcare system that just doesn't make sense. It's hard to understand. It's too expensive. You can't afford, all those things are out there in a reality of just the way the world works in American healthcare. And so everybody's got a Lucy. And so it's been a great rallying cry for us. And so that's us. That's our foundation. That's the core. That's the mission. It always has been and continues to be to today. What that's led us to is we took that initial inspiration and turned it into what's now a network that provides real-time, patient-specific, moment-in-time specific pricing in the ordering workflows of physicians. So we work with EMRs. We power their native features around real-time benefit is one of the things that we do. And it's doing, millions and millions of transactions now a month. And
Month.
yeah, so I think we're doing
So slow down for a second. Let's walk through that actual use case. So I'm a doctor. You're integrated with my EHR. I'm trying to put through, where am I? Am I trying to put through a refill request? Like what am I doing?
No, you're ordering a med. So prescribers sitting in front of a patient, they diagnose the patient with whatever they need to treat. They choose a medication. Usually that's from some list. Once they choose it from that list, it goes into a pending status. At that point, we evaluate the prescription. We send it out to our network of now nearly 300 million insured lives. That's about everybody. And what we get back is the moment in time specific price at that patient's preferred pharmacy and any benefit design complexity. So quantity limit, step therapy, prior auth, all that stuff. Um, in addition to that, we get alternatives. So it might be a lower cost drug, it might be a lower cost pharmacy, and then we return that into workflow. We only interrupt the doctor's workflow in any way if there's a lower cost opportunity. So, there are several scenarios where they're already making the right choice, so we don't bother them.
So it's kind of like when I'm driving somewhere and then Google Maps will tell me there's a faster route available. Click here.
Exactly. That's a good corollary. And so the goal is then there's lots of scenarios that are just outside of the purview of the provider because like why would they ever consider them? So albuterol, it's generic. If you're a parent, every parent's eventually going to get this prescription for their kid more likely than not. And one of those drug forms is probably $0 on your health plan, and every other one is more than $200. And there's absolutely no way for the prescriber to know that unless there's a real-time tool telling them, because it's likely that the health plan A, health plan B, and health plan C have all negotiated different deals for different prices with different drug forms. And so in a clinical day, you see 30, 40 patients. Those 30, 40 patients are on 10, 15 different health plans. Then you end up with this ballooning, permutation of possibility that's impossible for a human to manage. It's not visible, but even if it were visible, it would be too complex for anybody to manage in a 15-minute visit with a patient. So what we do is say, let's get the right answer. Let's find the most relevant alternatives. Let's put them in front of the doc only when they need them, and leave them alone when they don't, which goes a long way to drive the right type of behavior change. So we have health system customers that are seeing as high, north of 30% behavior change, where a third of the time when we present an alternative, they're accepting our choice, and which is huge. I mean, if you think about provider behavior change in healthcare, that's a massively difficult thing to do.
And what's the incentive for the health system? I understand the obvious incentive to the patient, it's cheaper.
Yeah, better price for the patient, better price, more aligned with the plan design for the health plan or the PBM. For the provider, there's 65 million callbacks a year that are associated with reworking medications. So getting that answer right the first time saves a bunch of downstream work for that provider system. And frankly, that's where patients go for those answers anyway, right? Like people, if a patient has a question about medications, they go back to their doctor. Like hard stop every time, first call, doctor. Nobody wakes up in the morning and goes, God, I really hope I talked about PBM today. No, PBMs serve an important role, and I'm not disparaging. I'm just saying those calls go to the doctor's office. So our opportunity is just to empower the already engaged moment between that patient and provider with the right information to make the right decision the first time.
So you're going to look at my plan as a patient, what I might pay for this drug that's about to be ordered, and then you're going to search the entire space for a cheaper option for me, given the context of my insurance plan, and then present that to the doc.
Yes, the only correction is we work with your health plan to make sure we're making the right recommendation, because they're the only ones that know that answer in a lot of cases, right? The formulary design, the benefit design is between the PBM and the payer, and so we're doing basically a mock adjudication in that case to get back the right recommendation.
So what is the role of if you can delineate the roles between the insurance plan company and the drug manufacturer, pharmaceutical company, what does that relationship look like?
There's a third entity in there, right? So there's plan sponsor, represented by health plan more often than not. There's manufacturer, and then between those two is a pharmacy benefit manager who is you know, demand side aggregation so that they negotiate with the pharma manufacturer for best price in its simplest form.
Okay. So
Um,
you have this person in the middle that's negotiating for a best price, and then that person then recommends or essentially sells what they determine to be the best price to the insurance plan, who then passes that off to the patient. Says, "We'll cover this."
you got it. That's the structure at a high level.
What is the opportunity or reality of um, fraud? Is maybe a strong word, but what is the how often is that entire middle piece actually happening with the patient's best interest in mind?
More often than they get credit for, to be honest. They, one of the things that's happened that's extraordinarily positive over the last 10 years is, generic dispense rate is north of 90%, probably north of 95% in most integrated health plans. Um, so there's, really high rate of adoption for generics that we can credit formularies for that designed by PBMs. Um, I think the complexity that's often cited these days is that, um, rebates are really complicated and hard to follow and hard to understand. And so it's hard to attribute how often those things are getting distributed throughout the supply chain. And so there's room for more clarity there. And there's a lot of complexity within the pricing between pharmacies and PBMs and all those things too. So um, hard to say it's hard to be abstract in that scenario because there's a bunch of scenarios where, those that are aggregating demand are doing a really great job of driving down overall cost. And then there are shocks to the system that make that really hard to do. So GLP-1s are a really good example of a shock to the system right now. They're really hard to manage because, $1,000 a month drug that 2/3 of the country is eligible for. And that's just not, it's not something any actuarial model has ever accounted for. So it sort of shakes the snow globe, and those are not simple moments to transition through as a
So,
country, as a system.
right. So, what are your thoughts on? I'm sure you're familiar with Cost Plus Drugs, Mark Cuban's new initiative.
Yeah, yeah, yeah.
What is your view of that, and how is that if and is that relevant to what you guys are doing?
It certainly is. I mean, I think at a high level, our goal is to reintroduce consumer choice at the point of care and throughout the patient experience. That's the consequence of e-prescribing is which we adopted through federal regs in 2004 ish, and it's the only time in human history we adopted a technology and consumer choice was limited. And so when you had a paper prescription, should you feel so inclined, you can go to every pharmacy on your street and get a price and compare it, right?
Interesting.
When we adopted e-prescribing, now it's routed directly from the
Uh,
EMR straight to the pharmacy. Someone made a purchasing decision on your behalf, and neither of you knew what it cost until you showed up to pay for
huh. Good
it.
point. Yeah.
And so what our network and networks like ours represent is an opportunity to reintroduce consumer choice. So we can say, hey, doc, you were going to make this selection. Um, think about these options. Better yet, doc makes decision. We engage the patient with relevant alternatives too, which we're doing in some ways.
Yeah.
So thematically, we're entirely aligned with the intent of Cost Plus. I think that we encourage price competition. We encourage ultimately finding best price for the patient, best price for those who are
Right.
managing risk, and I think it does good in both of those ways. The and it certainly seems to be having a macro impact because you
Yeah.
see some of the PBMs starting to offer cost plus type solutions within their formularies that they're selling.
So is that one of the things that because Mark argues that often their drugs will even be cheaper than the patient's copay for what their plan
Sure.
covers? Is that one of the databases that you guys check or not? Not yet.
We haven't connected to them yet. We're certainly willing and open to it, but we haven't. But I think it's absolutely a good alternative to have on the table. And some of you're seeing some of these big health plans start to unbundle and include those things, and to
Yeah.
the extent that continues to happen, we want to represent it at the point of care.
Yeah. So you guys, I think it's all coming together in my head now. So you guys are a tech piece that stands in between. The way you're reintroducing consumer choice is that you're a tech piece that stands in between the click of the button and the send, essentially, and basically holds that for a second, searches, make sure that's the best thing for the patient, and then you either you know uh, notify the doctor there's a better option, they can maybe go in that direction, or you just let it go through, essentially. Um, and so without the consumer having to make that choice, you're saying our sole choice is best, best price for you, and we're going to look at everything.
Yep.
And how many transactions did you say you guys are doing a month? How many transactions? You said 30% is what people are actually changing to go with something else, right?
Yeah, but we're seeing we're doing 11 million transactions a month, probably going to 18 million a month by mid-year.
That's amazing. Um, that's awesome. So Mark's actually coming on next. So I'll see if
Oh
we can
yeah,
make yeah.
send them our way.
Yeah. I mean,
We'd love to
it
talk to
sounds
them.
like a good business opportunity.
Yeah, absolutely. I think a lot
If
of what they're doing, and
if he
it
was,
seems like the absolute right type of partner for us.
yeah, that's cool. My only thought is that my understanding, and I could be wrong, it's my understanding is that plans aren't actually covering his thing yet. He basically is selling to employers and cash, basically, if his drugs are going to be cheaper than your copay, then it were to make sense for you to do regardless. That's my understanding. I could be wrong though.
No, I think that's right, and that's not entirely different than the way GoodRx approached the world, right? Those are discount cards; those are used instead of your benefit, where they're priced more competitively. So we work with those types of companies as well. So always welcome new additions to the network as long as it's increasing consumer choice and benefiting patients out of pocket.
Yeah,
Then
this definitely seems to
bring
be
it
his
on.
mission. So cool. All right, we'll
Yeah.
see if there's something there. You never know.
Right.
Podcasting and networking, all live.
All in
We'll
one.
see. Yeah, we'll see what happens. But that's great. Cool. So 11 million patients a month. That's fantastic. Where are you guys at as a company? You're obviously a startup. I mean, I mean, 10 years in. So,
We've
but
been at
where
it
are
a
you
while.
guys?
Yeah.
Yeah, you've been around a while. What does the company look like? How many people? What are your bragging rights as a company? What have you achieved?
Yeah. So we're about 42 from a headcount perspective. I mean, we've grown incredibly fast. We went, we were doing, as a matter of context, in 2019, we were doing a few thousand transactions a month. So now here we sit doing tens of millions. So that's, we're really proud of that. We think there's a few things that are really important data points. We've built now and launched prior auth at a couple of places. This is workflow embedded electronic prior auth, where we're automating using our integration into the EMR, the prior authorization process. Most of the way that folks approach prior auth is just to try and process them as fast as possible. Um, that's an important component. What's even more important is, can you avoid the prior auth in the first place? So back to that third behavior change, it also is translated into a third of the time we can help a doctor avoid prior auth and they don't have to do it at all. So that's huge. That's been a big achievement. We've taken, even where prior auth is required, a process that's taken 3 to 4 days for some health systems and taken it down to 3 or 4 hours. Uh, so that's been a big achievement. Um, we think we've identified $6 billion of savings opportunity in the last year for patients. So we're proud of that. We also did a study. This one, this one's wild. We did a study trying to find where there were $0 options for doctors that they weren't aware of. So we found that almost 50% of the time there was a $0 option drug available when the provider selected a drug that was $50 or more. So almost half the time there's a $0 option out there, and our job is just to get that in front of the provider, right? Like
What? Wait, say that again.
plug into our stuff.
Almost 100% of the
So,
time.
so almost half of the
Yeah.
time there was a $0 option available when
Wow.
something $50 or more was prescribed. Now, there's a lot of scenarios where they needed that $50 med, right? Like,
Right.
I'm not saying all of those are viable switch opportunities, but the total opportunity is nearly half of the
Yeah,
time. They could be paying zero instead of something more than 50.
that's wild. So what is so broken? How did we get here? How did we get to a point where there's $6 billion going to waste? Did you say a year or in its entirety of your work so far?
That was in the last 12 months. That's what
Oh
we
my goodness. Okay.
identified.
How did we it's wild. How did we get to a point where there is $6 billion of waste? How did we get here as a system?
Um, well, there's probably more than that, to be honest. That's just 6 billion in brand new scripts, right? Like there's, I think that 600 drug markets, 700 billion-dollar market, and they estimate that almost half of that's waste. Um, and I mean, so it's a confluence of factors. One is we took a really simple process that used to be doc prescribes med, patient gets med, and we turned it into this unbelievably complicated process for a bunch of good reasons. But it's complicated, right? So med gets prescribed, then you got to resolve a prior auth. If it's a specialty med, you probably have to resolve a specialty enrollment. If it's a high cost drug, you got to enroll in a copay assistance program so you can pay for it. Then you finally get the med, and then you got to enroll in an adherence program because you're a Medicare member and it's required.
Okay.
Um, and
What does that
so,
look like? What does that actually
so
mean?
all of those things, but that complexity exists for a few reasons. Is one, uh, deductibles used to be in the hundreds, they're now in the thousands. Copays used to be tens of dollars, now they're hundreds and thousands of dollars. So there is a real out of pocket strain that patients are feeling. At the same time, the plan sponsors are feeling an incredible cost strain, so they create prior authorizations to try and control costs. They do their best to manage risk, which creates complexity. And then, high cost specialty drugs, 50% of spend is now specialty drugs. That's 2% of the prescription drug volume that's now responsible for 50% of drug spend. And so there's lots of checks and balances and authorizations for those medications because they want to make sure only the right patients are getting those meds. And so that sort of all nets out as a expensive, highly complicated process. And and so I think the opportunity and all of that exists outside of what we're trying to do in a standard e-prescribing world. All of this is being managed through a process that's largely driven by faxes and flat files. So the timeliness of the information for those that are trying to make decisions is out of whack, right? So prescribers making a blind choice, the care team trying to resolve the prior auth isn't able to do that instantly. They're trying to take days to get the right answer to the right entity. The specialty enrollment processes are all the same questions you answered for prior auth going to a different set of entities. So it's just, the net result has been this highly complicated process. And at the end of the day, the patient bears the burden. So there's so many stakeholders trying to solve so many different problems from their own point of view. And the patient's left to advocate for themselves because they're the only ones that sees the whole thing from end to end. And so our goal is how do we start to connect these stakeholders into one cohesive network that allows us to help them all sing from the same sheet of music? Because I think at the end of the day, everybody's ultimately driven by the same incentives at the end of the process, which is patient has med, we want the patient to take the med because we're going to pay for that drug and we want to get the outcome. And it's just there's no connectivity between these entities. So our goal is to create that connectivity.
Yeah. Do you think that we're here because of just standard regulatory incompetence and just the nature of the beast, or do you think that it's a nefarious play by the pharma industry and it's a money-driven thing?
I think it's more likely the not necessarily regulatory incompetence, but it's boiling the frog type situation. Is that these things happen over time. One of the
Better,
industry legends I've
it's a
heard
more
is,
PC way to put it.
I mean, you think about prior auth, right? Like that is the one thing that everybody in healthcare agrees on is that prior auth should happen differently. Well, prior auth didn't even exist until the late '90s, and we think about prior auth as this thing that's just always been there, and it's a relatively recent phenomenon. And so these our assumptions about the way things have always been have a pretty limited time horizon, and I think there's an opportunity to do things dramatically differently.
Interesting. Cool. What does the future of Arrive Health look like? What are you guys looking to tackle in 2024 and beyond?
Yeah. Uh, Prior authorization automation front and center for 2024. Last year we acquired a company from UPMC in Pittsburgh. They This is an AI driven adherence tool. I think what that provides us is a couple of things. It's one, we want to make sure we're creating the digital capabilities required for health systems to create a really differentiated experience for their patients. So helping providers make the right decision the first time through that's Navigate, our point of care product. We're gonna help patients actually get their med through overcoming the prior auths and the friction in the middle of the process, and support care teams in doing that. So that's automating prior auth, that's automating benefit verification capabilities, those sorts of things.
But that's still
And
not patient facing per se.
that's right. That's care team tool.
Okay.
That's care team tool. And then ultimately, it's making sure patients actually take their med. Right. So it's get the answer right. Let's make sure they actually get it. And make sure they actually take it. And that's the focus for 24. I think it's expanding also the stakeholders that we're working with to drive affordability and access for patients. So insurance price is really important. It's our primary focus. But the reality is there's lots of other ways that patients need help paying for their meds. So expanding our ability to support patient affordability is a huge part of that. Those are the main ones, and I think it's, you know, making sure we're never losing sight of quality. I think we as a company we were incubated largely inside of the University of Colorado health system. So we've come at this both in the founding story from Kevin and our partnership with UC Health through um, through a very provider oriented point of view, that that patient provider relationship is the thing that matters the most, and that has the most leverage to drive positive change. And that'll continue to be our focus, and that's the foundation from which we think of solving all these problems.
That's awesome. Well, Kyle, I wish you tremendous continued success. Sounds like you guys are really doing something great. It's been and to spend 10 years in a thing and see some real progress is awesome. So congrats again on the company, and thanks for spending time today.
Yeah, appreciate the invite. Great to meet you.